lecture is for Chapter 5, Pregnancy and Lactation. This is specific to the conditions and diseases that can occur. So some of the things that we've talked about so far have been normal physiology. But there are some conditions that are common and sometimes not very common that occur during pregnancy and lactation that relate to the overall nutrition health. However, based on the way that I've presented the lectures previously, this lecture should kind of be, for the most part, a review of material we've already covered and should be relatively short. So we're going to start with GI conditions, and we've kind of already discussed this a little bit, the hyperemesis gravidium. This is when there is severe nausea and vomiting that lasts past that first trimester. As we've talked about, morning sickness can be a relatively common condition. However, when we get into this particular area, we are really concerned about mom losing weight during pregnancy and thus baby having low birth weight, which puts baby at a higher risk for other diseases. This only happens in about 2% of pregnancies, and we don't really know why it occurs. There may be some genetic component to it, but a lot of times with this, we're talking about bed rest and IV medications and nutrient repletion via the IV. It's typically recommended to these moms to eat as bland and as clear liquids as they can to try to keep what they can down. So for any mom experiencing diarrhea, no matter what the cause is, so whether it be a rotavirus or just IBS, the important thing is that we're encouraging these moms to rehydrate and correct electrolyte imbalances, because the last thing we want is for mom to become dehydrated and not have adequate fluids. So specifically, I don't know if you remember this from 219, but one important thing to remember is that taking in too many sugary drinks for treatment of diarrhea, so we're thinking about very sugary Gatorades, Pedialyte, things like that, may actually draw more water into the GI tract. And so it's really important sometimes to make sure that we're choosing the correct products, avoiding too much sugar, as well as mom could cut it down 50-50 with water. So constipation, we've kind of already talked about that it is a common problem in pregnancy. There are lots of reasons that we see it occur. We've talked about that the GI system has a lower motility as normal during pregnancy. There are normal physiological and hormonal changes that happen in the GI system. Some moms just have decreased activity. Sorry, had a pup that needed to be let out. Some moms just have decreased physical activity, and that can contribute, but also iron supplementation or sometimes prenatal vitamins can cause constipation. How do we treat that? Same as we treat normal constipation. We talk to our moms about taking in adequate fiber and adequate fluid with that, and reminding them not to take in too much fiber too quickly, so not to go from 10 grams to 30 grams overnight. Some additional things we can talk to them about is using prescription medications such as Miralax or stool softeners. Sometimes when they pick up Metamucil over the counter, if they're not taking in enough fluids, it can actually further constipate them. So I'm a little hesitant to do that. I normally always say food first. So I would recommend high fiber food items, or even like Fiber One bars before I would recommend over the counter like Metamucil. We don't want them to do laxatives, and here's why. You know, the GI system over time becomes dependent upon laxative style medication. Not to mention the fact that it can put anyone at a high risk taking in too many laxatives at a higher risk for dehydration and loss of fluids. So it can definitely go to the opposite end of the spectrum, and particularly for our pregnant moms, we don't want to take that chance. So I would not recommend that at all unless it was absolute last resort and OBGYN was on board. We talked a lot about GERD. We talk about it in 219. So remembering that GERD is the chronic and heartburn is typically a symptom. However, it's very common in pregnancy. A lot of times this is related to the weakening of the lower esophageal sphincter there at the top of the stomach, you can see. And that happens typically with the hormonal changes in pregnancy, and the very acidic contents of the stomach seep back into the esophagus. And that lining of the esophagus is not able to handle that acidity. There are some triggers that, although it is common in pregnancy, taking in certain foods can make it worse. With those, remember that that is typically spicy or tomato-based foods, chocolate, caffeine. We actually see it sometimes with high-fat food items because that sits in your stomach for a lot longer. Or eating right before bed. Think about it, you lay down, it kind of naturally, that gravity sometimes will take that acid right up the esophagus. So a lot of times with this, we want to recommend those dietary changes before medications, but to be really honest, with some pregnant moms, going ahead and putting them on a proton pump inhibitor or an H2 blocker, which are common medicines like Pepcid, Prevacid, Prilosec, might be what actually is needed. So we've talked a lot about obesity and being underweight during pregnancy and lactation. As we know, pregnancy and lactation both require extra kcals. Your BMR goes up. So the concern would be with those changes in your body that we are able to maintain that at a healthy weight. So just make sure you review those weight gain recommendations for pregnancy, whether someone be underweight, normal weight, overweight, or obese. Overall, we don't want to see weight loss during pregnancy. And once again, those weight gain goals really are based on that BMI category. So what happens if women don't gain enough weight during pregnancy, or they enter pregnancy underweight and they're just not gaining? Because if you look at the pregnancy gains for underweight, it's 28 to 40 pounds. And particularly if moms come into it underweight related to psychosocial issues such as eating disorders or disordered eating patterns, it can be really difficult for them to think about gaining weight. We know about 20% of women don't gain enough weight. And unfortunately, the concern would be that not enough weight is gained and nutrients are taken in to support fetus. So we really have to talk to these moms in very specific terms about what they can do to get in enough calories during the day. A lot of times that can look like talking about meals and snacks specifically. Sometimes some moms in this case do really well with a structured meal plan with built-in snacks at every 2 to 3 hours. For someone that's obese, talking to them about listening to their hunger and fullness cues and not tapping into that social or psychological eating perspective. And so as we talked about sometimes in 219 and during our crash course, sometimes we have to go back to the ABCs of behavior modification. And so if they are eating chips every night before they go to bed, what can we replace there that is a healthier option? And then making sure that moms engage in physical activity on a regular basis. We've already talked about the fact that most moms can engage in the same physical activity levels that they did prior to pregnancy, but those that maybe were not physically active can still do low impact exercises that could really benefit them and baby in order to prepare for birth. So one way to talk to women about weight, which can be a really sensitive subject, particularly during pregnancy, whether they sit on that side of concern for weight gain or coming into it obese and thinking about not gaining as much weight or not eating for two, is reminding them to aim for those smaller meals per day, making sure they naturally build in snacks. And making sure that those snacks are healthy choice snacks. So we're talking about nutrient-dense items, really not going longer than 3 to 4 hours without eating. The other thing is if you have an underweight mom, and typically we talk about this with anyone that's underweight, adding healthy oils and cheeses and sour creams and gravy to the dishes they already have can really bump up a kcal count. And the other thing is we've talked about DHA and EPA and some of those fatty acids that are necessary for the fetal central nervous system tissue development. We want to encourage them to consume those healthy fat items that would be rich in those, particularly cold water fish. avocado, olive oil, and healthy nuts and seeds. So I think we have already seen this on a quiz a little bit, and we've already talked about the necessity of iron during pregnancy. But iron is of particular concern because this particular deficiency is the leading cause of anemia in pregnancy. And it's really common in women in childbearing age anyway. And so especially if they come into it with already being iron deficient, we tend to be really concerned about that. And why? Because we see, particularly during the first trimester, that there can actually be developmental delays once baby is born, and differences in their cognitive function later in life. Now, when we're thinking about fetal growth in the last 20 weeks of pregnancy, iron deficiency can actually increase risk for preterm labor, for having babies that are low birth weight or small for gestational age, and even in the most severe consequences, maternal and infant mortality. So how do we talk to women about getting adequate iron? Well, we want them to take in about 27 milligrams per day, whether that's during pregnancy or lactation. And typically we can do this with a well-balanced diet. However, if we cannot do it with a well-balanced diet, a lot of times in pregnancy and lactation, we need supplementation. Now, then we can cause that issue with constipation, and that causes women to stop taking their iron. There are a lot of over-the-counter iron products out there, a lot of times called things like gentle iron, that are a different synthetic form that are actually a lot more calm on the GI system. So you may want to recommend that. The other thing is that we want to remember to encourage them to consume vitamin C rich foods with their iron to enhance absorption. So for example, if they eat a cheeseburger, including a tomato slice on it, if, let's say, for example, they're going to have some type of breakfast meat or eggs in the morning with breakfast, making sure maybe a glass of orange juice or some fresh cut oranges or citrus fruits to help enhance that absorption of the same meal. So just make sure you look over the good sources of dietary iron, because a lot of times we're concerned about women who may be vegetarian or vegan, and we really have to think about those non-animal or plant-based sources. Folic acid, I know you've seen this before. We talked about it in 219. This is the thing that is absolutely critical that for fetal neural tube closing, which typically happens around 8 weeks. If there is not adequate folate to go towards this, what ends up happening is babies are born with spina bifida, which has long-term, lifelong consequences. A lot of times we see developmental and cognitive delays. The lifespan of these children is typically quite low. Recently, maybe it's moved up into late 20s and early 30s, but it is very critical for a baby to be healthy. We know at minimum that women need about 400 micrograms per day, but if you look at most prenatal supplements, it'll provide about 1 milligram a day. So make sure you look over these great sources of folic acid. I know that was something that was on your quiz that you saw. Make sure you are familiar with it. One thing that's not on here is eggs, but leafy greens and citrus fruits. Another one to think about is we fortify all of our grain and cereal and bread products in the United States with folic acid as well. So any of those fortified cereals is also a good choice. One thing I want to talk a little bit about is gestational diabetes. So typically, as we discussed, in pregnancy, insulin resistance can happen. Now, when we see a true glucose intolerance in pregnancy, typically we don't start to see that happen until the second or third trimester. It impacts about 10% of all pregnancies in the United States, and it actually resolves after childbirth typically. However, it's these women that we're concerned about. If they have other pregnancies, they're at a much higher risk for having gestational diabetes again. They are also at a very high risk for type 2 diabetes later in life. Now, What we do know is the rates of this are increasing. So whether that be our food supply as a society, our food choices, what we do know is that we're seeing this more and more common. Now, a lot of times we have no rhyme or reason that GDM happens. We see it in people that we expect to see it, and then we see it in people that we don't expect to see it. So there's not a lot of rhyme or reason. When we talk about prevention, we talk about an overall well-balanced diet and being physically active. So maybe thinking about that adequate preconception care, but really there's no way to prevent onset of this. However, the treatment for gestational diabetes, I notice my slide cuts off here, is that we want them to maintain really stable glucose levels, similar to type 2 diabetes, with exercise and diet. So remember how physical activity can open up more glucose pathways in the cell, and the cell becomes more responsive to the body's insulin, so being physically active. Diet, we want to think about not restricting carbohydrates, but keeping them consistent throughout the day. So a lot of times we talk to people about carbohydrate counting, and what that is say, okay, I'm going to have 75 grams of carbohydrates at breakfast, and I'm going to have 75 grams at lunch, and I'm going to have 90 grams at dinner, and really keeping it a consistent dose throughout the day. So why do we care about gestational diabetes? Well, we know that moms not only have their own complications, but also there are severe complications for the fetus, particularly if those glucose levels are not well managed. One of the things we are concerned about is having really large babies. The extra glucose goes into the fetus and just continues to grow this really large for gestational age baby. Mothers that are a higher risk for preeclampsia and pregnancy-induced hypertension. Babies are at a higher risk to develop cerebral palsy. And even on the really dire end of it, if a baby has to try to fight through those high glucose levels all the time that mom is not controlling, we sometimes see stillborn and fetal death, which actually happened right before I went to one of my rotations at a gestational diabetes clinic, that there was a mom that had a stillborn baby. So thinking about cardiovascular conditions, hypertension, remember, is high blood pressure, and just make sure you're familiar with this definition. We looked through the different stages of it, which the American Heart Association has actually gauged back a little bit. But as far as I know, according to our book, 140/90 is what we're going to go with. That's typically the clinical standard for diagnosis. However, they are watching people at that 130/80. But for study purposes, let's just go with 140/90 as being that cutoff point to move into high blood pressure or hypertension. Now, within pregnancy, there are 3 different kinds. So you have chronic hypertension, somebody who came into pregnancy with high blood pressure issues. Gestational hypertension, or sometimes you'll hear me call it PIH, pregnancy-induced hypertension, meaning it started to occur during pregnancy, not a previous existing condition for mom. Or preeclampsia, which is the most severe. Unfortunately, what happens with maternal hypertension, no matter the type, is it prevents that placenta from getting enough blood. And so clearly that can be a huge concern. Baby can't get enough blood, baby can't get enough nutrients, can't get enough fluids. It's a real concern. Now, I do want to talk a little bit about preeclampsia because it is quite serious. Typically, these are the moms where it's an extremely high blood pressure, but we also see them spilling protein in their urine. Normally, it does occur after the 20th week of gestation, and typically it's about 10% of first pregnancies. Here's the thing. Women are screened regularly during pregnancy for preeclampsia. However, those at a higher risk typically need specialist care because preeclampsia can actually push women into early preterm labor, maternal death, stillborn. It is a very serious condition. How do we treat pregnancy-induced hypertension? A lot of times it's bed rest. I know when my blood pressure got very high at the end of my first pregnancy, they said, you're in the bed all weekend. Watching sodium intake, we know that as a society, we tend to take in way too much sodium. So watching that, kind of reducing our fast food intake or processed food intake, and drinking at least 8 cups of water per day, so providing the body with more water. Hyperlipidemia, one thing you might have read in the book is that blood lipids actually naturally increase with pregnancy, so we tend to see a natural increase in triglycerides. However, if they start to get way too high, and with way too high, we're talking about double and triple what would be considered normal during pregnancy, they have an increased risk of an inflammation of the pancreas. And unfortunately, what happens when a mom develops pancreatitis, particularly late in the pregnancy, we can see both maternal and fetal death. So it's very important that if those trigs get way too high, that we actually do need to treat them with medication management. For a mom that comes to pregnancy with existing hyperlipidemia, which is extremely common in our society with our high-fat diet, they need to continue on that DASH diet and manage their medicine adequately. One thing I definitely do want to talk about, because it is really important, health is not just physiological, it's some psychosocial stressors. So I feel like it's gotten a lot more common to discuss postpartum depression. However, there can be perinatal depression. So sometimes if a woman is having difficulty getting pregnant or is starting to go through IVF, there can be prenatal depression. Maybe the pregnancy experience was not exactly what she thought it would be. So there are different stages that we can actually see depressive symptoms. The reason we're concerned about this is we actually see negative health outcomes related to the depression. The moms are less likely to take care of themselves during pregnancy and even lactation. They're less likely to watch some of these warning signs that may have prompted them to the doctor. So other than the psychosocial components, we actually see these moms go into preterm labor. We see bleeding a lot of times that should not be happening. Moms just generally not feeling well. For the infant, we actually see that they are at an increased risk of failure to thrive. They don't sleep well, they're irritable, they get ill more and more often. And even when they're born, they may not be as healthy as they could be. So looking at those APGAR scores, which is that quick assessment they do of an infant right away when they're born, sometimes they are not as healthy. So we are really concerned about this. We want to be open and have that conversation with our moms. Oh, it all went down. Okay. We want to be open and have that conversation with our moms and try to be as open and honest about it as we can, so that we can get these moms the help they need. Okay. Now, let's see if we can't finish this out. All right. So as far as lifestyle things, you can talk to pregnant and lactating moms. We want to see them doing both strength training and aerobic activity. Typically, they can continue their normal exercise that they did prior, sometimes with small modifications. But we do want to see them doing at least 20 to 30 minutes of moderate intense exercise on most or all days of the week. This will really help prepare their bodies for birth and really just in general be good for them. One of the things that we're concerned about is women smoking during pregnancy. We know that what happens, typically we see low birth weight infants and congenital malformations for baby, but babies can actually be premature and mothers can have spontaneous abortion. When a mother smokes during pregnancy, it actually exposes that fetus to more than 4,000 different chemical compounds they would not normally be exposed to. So it is really hard on their little bodies. And typically we see our smoking moms do not eat as well. So there is some concern over, okay, we're smoking and that's a whole issue, but then there's typically a poor dietary quality that's associated with it. Unfortunately, the numbers really range, but 13 to 25% of pregnant women continue to smoke. In our area, when I've talked to the State Department of Health and even Blount County local health department, smoking cigarettes has still been, or smoking tobacco products, has still been an extremely prevalent issue, particularly in pregnant moms. So thinking about alcohol, one major concern is that consuming alcohol, especially during the first trimester, is really harmful. The concern about this is, as we talked about, is that 50% of pregnancies are unplanned. And so if moms are regularly consuming alcohol and not realizing they're pregnant, there can still be growth development issues and actual structural and functional defects. One of the most severe instances is when an infant actually has fetal alcohol spectrum disorders. It used to just be called fetal alcohol syndrome, but we've realized that babies can have a wide variety of growth and development issues. And so typically we now call it the FASD. But these babies tend to look kind of similar. They tend to have a small head and there tends to be a very flat face with a thin upper lip, a lower nasal bridge, typically a short nose, and very small eye openings. And that is all for Chapter 5.